Dah. Mana lagi yang lain?
We still have another class, Dato.
Ya.
Just sikit je lagi dah nak habis dah.
Dengan siapa kelas?
Dengan Dr. Mosad and Dr. Alwi.
2 kelas yang ada hari ni?
Apa ni? Combine. Maksudnya ada dalam tu ada Dr. Mosad dengan Dr. Alwi sekali.
12.30 tak apa.
12.30? Okay. Thank you, Dato. Datuk, kami baru habis kelas. Nak start
Ya.
sekarang kah? Nak start, saya panggil orang.
Rehat dulu lah you all. 12.30 lah.
Okay. Thank you, Datuk.
Binatang yang paling setia tak pernah selingkuh adalah buaya. Jadi kami ingin dia setia macam buaya selama dia di air. sampai buaya ini naik ke dalam. Apalagi kalau sampai
Dah, sudah.
Dah semua dah ada.
Tu dibesarkan ya. Siapa present?
Doktor.
Sekejap.
Saya Novara.
Dua apa ni?
Group 3.
Year berapa ni?
Year 5. Group 3.
Year 5.
Year 5.
Group 3 year 5
Betul.
Ini berapa bulan? 2.
2 hari bulan 12.
No. Okay, present.
Okay, so my name is Novara Iza. I will be presenting regarding the lumbar puncture. Okay, next. But before that, I would like to tell regarding the anatomy of for the lumbar puncture. So for the for the anatomy, we know that lumbar puncture is we want to get the cerebral spinal fluid from the subarachnoid space. So during newborn, the inferior tip of the spinal cord, we know it ends at L3. But as it grows, as the child grows, it will end at L1 and L2 during adult. So we aim for the lumbar puncture, the level of below L2 and L3 for the child less than 12 months. As we can see at the right picture, where it is said that for the child at L3, while for the adult, the end of the tip will end at L2. Okay, so we will move at the left picture. So I want to introduce to you guys, when we do lumbar puncture, we will go through these layers. So the important layers from the skin will enter to the subcutaneous layer. And then there are 3 ligaments, which is supraspinous ligament, intraspinous ligament, and ligamentum flavum. So once it enter, then it enter the dura mater and arachnoid. So when we hear the pop sound, it is due to the penetration of the 3 ligaments. Okay. Okay, next. So the anatomical landmark is where we take both highest point of the iliac crest, and then we visual imaginary line between the 2 iliac crest, and then we detect the level of L3. So that's how we detect the anatomical landmark for the lumbar puncture, and then we'll mark it for whether with a pen or you mark it with your thumb. Okay, next. So the indication for the lumbar puncture, the first one where especially in newborn or infant, in emergency cases when we suspected there is meningitis or encephalitis, or sometimes we suspected subarachnoid hemorrhage. The second thing that we do lumbar puncture is when in malignancy, it is actually the method for intrathecal chemotherapy. Intrathecal chemotherapy. And the third one, sometimes we do diagnose neurometabolic disorder such as intracranial hypertension, multiple sclerosis, and also Guillain-Barré syndrome. As we know in Guillain-Barré syndrome, we have a special characteristic where elevated protein despite the normal level of white blood cell. Okay, next. Okay, the contraindication, we must first exclude if there are any causes of increased intracranial pressure. So that's why the need to perform a CT or MRI brain before to avoid brain herniation, the complication. So the second one is if there are any bleeding tendency, especially to do investigation if there are any prolonged PT or APTT, or any low level of platelet, or any high level of INR. So if we do lumbar puncture in patients who have bleeding tendency, it will have a massive, it will have complication of excessive bleeding. So we do not want that. The third one, contraindication for any skin infection over the puncture site, such as cellulitis. We do not want to have the complication of bacterial meningitis. The fourth one is patient with hypertension and capillary. And the fifth one, for patient, the contraindication for patient children with respiratory distress, we do not want the risk of amnia or hypoxemia. Okay, next. So the equipment, I will show the picture later. We must have a sterile set and then a sterile bottle. We usually have 4 sterile bottles. The first one is for the test for the gram stain and bacterial culture. The second one is for CFS glucose and protein. The third one is for CFS cell count and differential. The fourth one is for viral, fungal, and fungal culture and any other needed special chemistry. The third important equipment, we must have a spinal needle around 20 to 22 gauge with length of 1.5 inch with stylet. So for lumbar puncture, we have a needle with stylet. I will show you in the picture. But for children with more than 12 years old, usually the length is about 3.5 inches. Okay, next. Okay, so this is the sterile set. On the left side, we have the sterile biopsy taping set. Usually, it comes together with grip and also the sterile PPE. We have the sterile glove, and then the below one, manometer. Usually, we do not do manometer actually to measure the pressure. The pressure once we do the lumbar puncture, we measure the pressure of the opening. So usually did not use manometer because it's difficult, especially in a struggling or uncooperative child. Okay. So the needle on the right further side, where we have the spinal needle with a shrink, 2 to 3 ml shrink. The spinal needle, we need to check it is a stylet spinal needle, and then we have cleaning equipment, which is betadine is the iodine, and also ethanol about 70%, and also the local anesthetic like lidocaine, which is 1%. Okay, next. So this is the procedure. I will explain first, then we will watch a video for a clearer flow of lumbar puncture. So the first thing that we must do for lumbar puncture is to counsel the guardian or counsel the parents regarding the safety of lumbar puncture. We do not want to have any worriness from the parents or any stigma regarding the complication of the lumbar puncture. So after we get the consent, a written consent, we start the procedure with, of course, giving a local anesthetic. It can be midazolam or lidocaine, and then prepare the 4 tubes that I'm talking about to take by preparing the tube, opening the tip to get ready during the lumbar puncture. And then third, we place the child in recumbent position. So recumbent position, later you guys can see in the video, we must have a curved back to open the intraspinous process. So it will be easily to get the lumbar puncture. So monitoring is also important to monitor the oxygen saturation continuously throughout the process. And then we do the landmarking, just I show you in the earlier slide. And then we clean the area with iodine and also alcohol, and prepare the needle with the stylet at the marked area you guys already marked, which is the L3 level or below than that. Okay, next. Okay, so when you guys prepare the needle, basically advance at the point side, and then penetrate the layer until you guys hear a pop sound. So usually when we pull out the stylet needle, there must be a CFS fluid came out. So there's when you guys prepare the 4 bottle. So after we get the needed the suitable amount for the test, then we slowly insert back the stylet and then pull out the needle and then put the bandage over it. So we want to make sure the child lies supine for the next 4 to 6 hours until he recover from this. If we given any sedation prior the procedure. Okay, next. Okay, can you play the video?
apa Hiza?
Boleh ke? It's a video je.
Boleh pakai apa?
Yang Hiza send ni tadi ada send apa?
Boleh ya? Boleh video tak?
No, the video is embedded. You can just click play.
Okay, jap.
Kenapa?
Oh ada ni.
Okay. So first we do the landmarking. The landmarking, like I say, the highest point of the two iliac crest. So this is a newborn, a small child. So we do landmark with both our hand, and then we have the imaginary line between the two iliac crest, and then you mark it with your thumb. Okay, so that's how you mark it. So you can just boleh. So you can just when you mark it, you just stay put your thumb at the mark area, or you can. Okay. So you make sure it is stay put where you mark it. So this is the sterile equipment. Like I say, you must prepare, open up all the 4 bottles before doing the procedure, so you won't make any mistake. And make sure everything is set in order. Okay, so this is the stylet needle I'm talking about. So it is around 22 to 24 gauge. So that's how the stylet look like. So positioning, we need a help from nurse or experienced doctor to position the baby or the infant in a recumbent position. So we want to in a curl. So usually we hold the hip and also the shoulder. So we want to open up the intraspinous process. But sometimes in our cooperative style, we'll give sedation if needed. Okay, we want to make sure when you hold the infant, it is aligned with the perpendicular with the table. So you won't miss the marking or the level of you're going to do the lumbar puncture. So give the alcohol, 70% alcohol and iodine in circular motion, and then we put the sterile drape over the around the opening that we mark, this right, left, and up and bottom. Okay, so the mark part, you put the stylet needle, and then you must position the needle towards the umbilicus, not directly perpendicular, because it will hit the bone. So this is the technique that we need to know. So it will actually reach up until the subarynoid space for the CFS fluid. So when you you try to pull out the stylet and then see if there any CFS fluid came out. So if there any CFS fluid came out, you take if there is no CFS fluid, you put back the stylet and then try to advance furthermore deeper. So that's when you get usually that's when you try to get the CFS fluid. So get into the 4 bottles, and then after you did the procedure, you pull out and then put it over a drape over the puncture side. Okay, that's all. Next. So the complication usually we have is sometimes the infant can have headache or back pain. If the patient happen to have a prolonged headache, we want to suspect any complication of infection or spinal hematoma. And then the brain herniation is because due to if we did not rule out any increase of intracranial pressure before doing the lumbar puncture. And then the third possible complication, if there are any bleeding tendency, it can cause the hematoma at the spinal side. So we want to continuously monitor if there are any possible complication of that. Okay, that's all from me.
Any question? Any questions? Tak ada, okay. Next.
Next is my part. So I'll be
Siapa
discuss.
present?
Saya. Dengar tak? Hello?
Ya, tapi nama you tak ada
Oh,
sini.
sorry.
Zain
Muhammad Zain.
Samsi.
Muhammad Zain bin Samsi.
Okay.
Okay, so next we'll be discussing about electrocardiogram in pediatrics. So first we'll be talking about lead placement of ECG. So for lead placement, so we have for coronal plane as well as vertical plane. So for coronal plane, we must put the lead at the left arm, right arm, left leg, and also right leg. So this is for AVR, AVL, AVF for lead 1 Roman, 2 Roman, and 3 Roman. So next is for the chest lead in pediatrics. So we have it's almost the same as the adults, but they have sometimes we can put V3R and also V4R for the right side. So let us go one by one. So lead V1 at the fourth intercostal space, right sternal edge. So at this area, V1, and V2, same, fourth intercostal space, but at the left sternal edge. Next, we must put V4 first before we put V3. So V4 is at the apex of the heart, which is the fifth intercostal space, mid-clavicular line. So after that, then we put V3, which is in the middle between V2 and V4. And next, we put V6. So V6 is at the fifth intercostal space, mid-axillary line. So V5 is in between V4 and V6, or at the anterior axillary line. So as I mentioned, sometimes you have V4R and also V3R. So V4R, the same as V4, but except it is at the right side. So it is at the fifth intercostal space, right mid clavicular line. So V3R is between V1S and also V4R in the middle. So this is the what the lead represents. So V3R and V4R represent the right ventricle. V1 and V2
Okay,
represent
semula boleh
also.
present yang tu balik semula tak?
Oh sorry.
Sing tadi.
Oh okay.
Yang ni. This part saja. Okay, semula.
Okay, so we have V1 until V6, and sometimes in pediatrics we put V3R and V4R. So for V1, we put it at the fourth intercostal space at the right sternal edge. And then we put V2 at the fourth intercostal space at left sternal edge. And then after we put V2, we put V4, which is at the fifth intercostal space, mid-clavicular line, which is the apex of the heart. And then after we put V4, we put V3, which is in the middle between V2 and V4. After we put V3 and then we put V6 first, which is the fifth intercostal space at the mid-axillary line. And then we can put V5, which is in between V4 and V6. Or the exact landmark is fifth intercostal space at the anterior axillary line. And then after that, we sometimes we put V4R and V3R. So V4R is the same as V4, except it is on the right side. So it is at the fifth intercostal space, right mid clavicular line. And then V3R is between V1 and V4R. So what the lead represent is, for V4R and V3R represent the right ventricle, V1 and V2 represent the septal leads, septum of the heart. And V3 and V4 represent the anterior part of the heart. And then for V5 and V6 for the lateral part of the heart. And sometimes we also put posterior leads, which is V7. So that is all for the lead placement. So let us move on to how to read the ECG. So this is the basic, the fundamental of the ECG. So the fundamental of the conduction of the heart. So first of all, it is from SA node and then move on to atrial muscle fibers. And after that, it will go to AV node, atrioventricular node, which is will be delayed. The conduction will be delayed at the AV node. And then after AV node is bundle of His, and then right bundle branch and left bundle branch, and last but not least, and it will go to Purkinje fibers at the ventricles. So the basic concept of ECG is that if the depolarization conduction of depolarization move towards the lead, the ECG will deflect upwards, while if the depolarization move away from the leads, ECG will deflect downwards. But for repolarization, if it moves towards the lead, it will deflect downwards instead. So it is vice versa to depolarization. So this is the calibration of the ECG. So what I want all of you to focus is these last 2 points, which is one small box and one big box. So one small box represents 1 millimeter. This is important because some of the books will mention 1 millimeter or or in seconds instead of in boxes. So one small box is 1 millimeter, and for seconds it is 0.04 seconds. And for one big box, it is 5 millimeter, and it consists of 5 small boxes. So 0.04 times 5 is 0.2 seconds. So that is all. And then how to calculate the rate of the heart. So it will be divided into 2 rhythm because if irregular rhythm, we cannot do the calculation for regular rhythm. So for regular rhythm, the formula is 300 divided by number of big box of 1 RR interval. So as we see right here, so this is R, this is another R. So this RR interval is about 5 big box, right? 1, 2, 3, 4, 5. So 300 divided by 5 is equals to 60. So about 60 in this particular ECG, the heart rate is about 60. But if it is an irregular rhythm, so we need to do this formula. So in main lead, usually 50 bit boxes. So we count the number of QRS complex. So in 50 big boxes, we count number of QRS complex, and then this number of QRS complex, we times 6. Because in 50 big boxes, we have how many seconds? 10 seconds. So 10 seconds times 6 is 60 seconds.
Okay, not remind you, this lecture is procedure, not interpretation of procedure result.
Okay.
Understand now? It's okay to give some interpretation, but no need to give a. So this one no need.
Okay.
Okay, no need. What we want you to learn is how to do the procedure. And then you have to show to us the ECG. Ada filem buat ECG procedure, ada ECG tak?
Film.
Ada tak video how to put the ECG?
Ada.
Tak ada. So that's what we want.
Oh, okay.
It's not for interpretation of the result. Ni tak habis tau tak? ECG ni detail. And in pediatric ECG tak payah hajar because very detail, no point, you all tak remember pun. No, even apa tu, your most of the times we want you to know basic, even tadi so detail, I don't think not for you all pun. Dia pun susahkan diri.
Okay, sorry, I didn't know.
You don't know because our objective for this one is procedure. How to do the procedure. Can go to basic interpretation tapi tak payah nak pergi detail sampai yang macam ni. Tak, go to your slide lagi tengok. Lagi ha di soal tak payah, lagi tak payah, lagi tak payah, tak payah, tak payah, tak payah, tak payah. No need, continue. Because it's not about apa ECG. You baca tak apa dia punya lecture ni? Is the
Procedure.
procedure
Presentation, yes.
Yes, we don't ask you to interpret the ECG.
Okay. Faham.
So ada tak ECG punya ni? Tak ada?
Tak ada.
How to put the ECG semua tak ada? Ya? Itu yang kita nak. How you calculate the four intercostal space, how you to calculate this one, where to put,
Oh, okay.
You understand?
Yeah.
Where to put the picture. Okay.
Okay.
Proceed next one. This one tak perlu semua tu. Next.
Okay, Assalamualaikum. Dato. So my name is Shah Al-Hadi. So I'm going to explain about chest physiotherapy and suction, airway suction. So first, I will explain a bit about the indication of chest physiotherapy, which is the first one is to stimulate productive thought in children.
Shah Al-Hadi.
Yes, Shah. Yes, Shah Al-Hadi. Can you hear me?
Yeah. Okay.
All right. Okay. So back to my presentation just now. Its main indication is to stimulate children to have a productive cough lah. And then in case of for example in pneumonia or acute bronchiolitis, in which the children have increase of mucus secretion, so you want to expel that secretion lah, to remove the secretion. So there are a few contraindications in chest physiotherapy, which in case of acute hemoptysis, coagulopathy, or in rib fracture, this chest physiotherapy can worsen rib fracture and can lead to further complications like pneumothorax and so on. So chest physiotherapy consists of these three, as you can see on the procedure part, which is the first one is the postural drainage, which consists of a few positions that we can do to assist drainage of this mucus secretion. And then these postures should be combined with another two actions that we must do, which are the percussion and also vibration. So percussion, basically we do a C shape or cup hand, and then we do rhythmic clapping of the region that we want to clear. And then vibration is basically a sustained and downward vibration of the hand, which basically we put both of our hands down together, and then during when the patient expire on expiration, then we do a sustained downward vibration on the area of the chest that we want to clear the mucus lah. So this procedure is important because sometimes we need to teach parents on how to do this chest physio, like percussion and vibration. And then complications include oxygen desaturation. As I mentioned just earlier, it can lead to rib injury, vomiting, aspiration, and also bleeding in the lungs. So next. Okay, so here are the postural drainage image, which we can see that is a few posture that we can put the child in to assist clearance of the mucus secretion lah. So as you can see on the top left is the position in which to clear the upper lobes and the apical segment. Position 2 on the right side is to clear the posterior segment. Position 3, the third picture, the upper lobes, to clear the upper lobes, and so on. Middle lobe, and then lower lobes, lateral anterior basal segment, lower lobe posterior, and so on. And this posture should be combined with, as I mentioned just now, the percussion and also vibration. So here are a few of the equipment that we need for this procedure, which is for post procedure, in which after the mucus is cleared upwards, and if the patient has difficulty to expel the mucus too, then we need the thing like suction catheter, connection tubing, suction source to remove this sputum and mucus secretion lah. And then post procedure we need to also auscultate the lungs and so on. So can you play the video?
The patient's lungs and listen for wheezing or crackles or aeration that is not equal on either side. I'm just going to listen to this baby now. Also, assess the patient's ability to be placed into the different postural drainage positions. If the patient has lines, tubes, IVs, that may keep you from doing that, or if the patient happens to lower their oxygen level in one particular position, you would want to know that prior to starting. Get a set of baseline vital signs and a baseline pain score and find out to make sure that the patient doesn't have any causes of pain in the chest area that would keep you from doing this procedure. Also make sure to explain the procedure to the patient and family. As I said, parents can sometimes be a little bit concerned when they hear the noise of percussion and think that it may be hurting their child.
Procedure.
I'm going to start first by just talking about postural drainage. I'm going to talk about each of the techniques and then I'm going to demonstrate them on this baby. So first would be postural drainage, and that just means the positioning of the patient to allow gravity to help to mobilize secretions. This is done in conjunction with the percussion and vibration. And if a patient can't tolerate all the position changes that may be involved, modifications certainly can be made, or the patient can be kept either in a flat or elevated position through the entire. There are generally 6 positions or basic positions that you can use, and I'm going to demonstrate those after the end of this talk. Now I'm going to talk about percussion. Percussion is a painless rhythmic clapping with a cupped hand over an area of the chest. You basically want to take your hand and make almost a C with it, and you want to have a loose wrist. And the way to percuss is to go over an area of the chest and getting the C against the chest so that there is a pocket of air there that creates a nice seal for doing the percussion. You would perform percussion for 1 to 2 minutes in each of the given areas, and that is done to help assist mobilization of secretions. Following that, you can go ahead and do vibration, which is basically a sustained downward vibrating motion with the flat part of the palm. It's important to only do the vibration piece of this when the patient is exhaling. It also helps with mobilization of secretions. So after you're done percussing, You can put your hand flat, you can use your other hand to help you, and when the patient has an exhalation, you can just vibrate very gently. I find that most babies actually are very soothed by this procedure. Some people, because you can end up making a loud clapping noise, patient or parents can be afraid that children are being hurt, but they're not being hurt. And as I said, most babies actually find this to be very soothing. When doing the actual procedure, you want to continue to look at the patient's vital signs, how their oxygenation is doing, the patient's tolerance to the different position changes, the tolerance to the actual percussion and vibration, how strong the patient's cough is, their ability to cough and mobilize secretions, and how their overall comfort is. I'm going to go ahead and start to get ready to do the actual procedure by putting on my personal protective equipment. Now that I've assessed my patient and prepared the family and the patient for the procedure, I'm going to go ahead and start. I'm going to do 6 different positions on the patient. As I mentioned before, you would normally go for 1 to 2 minutes in each position. For the sake of this video, I'm not going to do the full 1 to 2 minutes, but that's would be expected of what you would do. I'm going to start with the anterior segments of the upper lobes. The patient should start out supine in a flat position, and I'm going to start with percussing above between the nipple line and the clavicle line. First on the right for 1 to 2 minutes, and then on the left for 1 to 2 minutes. So I would start on the right. I would do percussion. I'd be noting how the patient is tolerating it. Be looking for any color changes or oxygenation changes in the patient. I would continue that for 1 to 2 minutes, and then I would follow that with some vibrations. I would wait for the patient to exhale and vibrate. You do that 3 or 4 times. You see if you're starting to get any productive secretions from the patient. Then you would move on to the left side and continue to do that for 1 to 2 minutes as well. After finishing the anterior upper lobes, you want to move on to the posterior segments of the upper lobes as well. If you start with using the right side, you can keep the patient flat, but when you come over to the left side, you want to elevate the head of the bed some and go ahead and percuss basically between the spine and the axilla. And again, using that cupping motion for 1 to 2 minutes as such. And at the end, you want to wait for the patient to exhale and give a few good vibrations. If the patient needs any suctioning, you could go ahead and do this at this point and before you move on to the next position.
Point of clarification. Please note that we will now show the appropriate patient positioning for the 4 remaining positions. It is expected that you would continue to perform percussion and vibration for 1 to 2 minutes on each side in each position, as previously demonstrated.
The next position that you will do is the anterior mid-lung. For this position, you preferably want to have the patient in about a 10-degree slope downwards, as long as the patient can tolerate that. I'm using a pillow to help position my patient, and I have one little pillow under her head for comfort. I have her hand up over her head, but whatever is most comfortable for your patient. So once you have the patient in a good position and the patient's on their side, you want to percuss based over the nipple line that is most adjacent to you. So again, you want to do 1 to 2 minutes of percussion followed by some vibration. The next position, you'll just move the patient back supine, keeping her head down the 10 degrees if at all possible. I'm going to remove her pillow now to help get a better position. And now I'm going to try to do the chest BT in the anterior bases of the lower lobes. I'm going to percuss below the axilla over the lower ribs, followed by some upward vibration, and repeat on the left side. Now you'll go ahead and work on the lateral bases of both sides. Again, get the patient in a head-dependent position of about 10 degrees, as long as the patient is comfortable. And you want to first do percussion on the lower ribs along the side. So this is going for the lateral bases of the lower lobes. followed by vibrations on exhalation. Then you would turn the patient to the other side and do the other side. And then the last position would be the posterior bases. So if the patient can tolerate, you can bring the patient a little bit more prone. If the patient doesn't tolerate a full turn, you can do a modified turn. And again, you're going to do the cupping on the back side. Be careful not to overlie the spine or to go near the kidneys, followed by vibration. Once you're all done with all of the positions, the 6 positions that I showed you, you want to bring the patient back supine and make an assessment of the baby and decide whether the patient needs to be suctioned or to help the patient with their cough.
Post-procedure assessment and monitoring.
You there?
Suction mana?
Okay, we continue with airway suction. Suctioning, basically the indications is when we suspect there is suspected suffocation, and then the patient, the child have takes greater effort for breathing, and then on auscultation we can hear wrong cry, and also in children that have inadequate cough and inability to swallow the secretion. So contraindication for airway suctioning includes nasal, facial, or basilar skull fracture, and coagulopathy, which is platelet, low platelets. And then the procedure includes nasopharyngeal suction and also oral suction. And then a few complications of this procedure includes spasm of the larynx, bronchospasm, oxygen desaturation. It can lead to trauma, any airway, upper airway trauma, and then there is a risk of vomiting and also expiration. Okay, equipments that are needed for this procedure includes soft suction catheter and also rigid suction catheter. Rigid suction catheter is usually used for an older child, and we need a suction source and then lubricant to lubricate the end for the catheter before inserting it into the oral cavity for suction. And then we need personal protective equipment, PPE, gloves, as well as mask and face shield. So as you can see on the photos I provided below too, the picture on the upper thing too is the soft suction catheter. Meanwhile, the lower image is the rigid suction catheter. So can you go to the videos?
I am now going to demonstrate the procedure for nasopharyngeal suction. Before I begin though, I'm going to start by preparing the patient. For a small infant, if there's a parent available in the room, I'll ask the parent if they want to be present for the procedure to help the baby through it. For older children, you should prepare them for what you're going to do, and if they're old enough, they can help participate by either counting down or doing something else that will make them feel more comfortable. Always want to make sure that the baby or the child's head of the bed is up at 30 degrees, as well as make sure that you have oxygen nearby in case the patient has any complications, and have your suction source ready. I'm now going to wash my hands and get my gloves on. I'm going to wash my hands with an alcohol-based hand sanitizer, or you can wash with soap and water. Nasopharyngeal suction is generally a clean procedure, but you could use sterile gloves as well. I'm going to go ahead and use a size 5-6 soft suction catheter to suction this baby. You might use a larger catheter such as an 8, 10, or 12, depending on the size of your patient.
Point of clarification. choosing an appropriately sized catheter. It is important to select the appropriately sized catheter for your patient based on the size of his or her nares. The catheter should be 1/3 the size of the opening of the nair. This will allow the catheter to be large enough to remove secretions, but not so large as to obstruct the airway.
I'm going to remove my catheter and keep the tip clean until I put it into the patient's nose. I'm going to hook up my suction to the catheter, and I'm going to test the suction to make sure that it's not too high. That's just right. I'm also going to lubricate the catheter to make sure that I don't cause any undue trauma to the patient's nose. I'm going to get ready. I'm going to have the patient prepared, and I'm just going to hold on to this baby's head a little bit just so that the baby doesn't try to wiggle away from me. And before I start, I'm going to measure from the baby's nose to ear to get an approximation of how deep I'm going to suction on this baby. And that's about at the 10 mark. And then I'm going to prepare, if a parent is with the child, to prepare the parent as well as the child. I'm just going to hold on to this baby's head just so that the baby doesn't shake their head and try to avoid the suctioning. I'm going to gently insert the catheter without any suction applied. I'm going to put the catheter in, and if I need to, I'll twist the catheter just a little bit to help it go down. I'm going to get to about that 10 mark, and then I'm going to apply suction and continuously apply suction as I remove the catheter. As I remove the catheter, I want to note the color and consistency of the secretions and whether there's any odor.
Point of clarification. Duration of suctioning. Please note that you should limit each suction to 3 to 6 seconds.
I'm going to give the patient a rest period of about 30 seconds to recover from this nasal suction before I begin to suction again. If the patient didn't cough, you might want to try to go in the other nair, or maybe go just a teeny bit deeper to stimulate a cough if the patient in fact is able to cough for you. I'm going to go down one more time now. Now I'm going to apply suction. Again, you can roll the catheter on the way out as well. I'm going to examine the secretions. I'm going to monitor my patient and see how my patient has responded to that procedure.
Procedure: oral suctioning.
I'm now going to review the procedure for oral suction. You may do oral suction after you've nasopharyngeal suctioned a patient, or you may just do oral suction alone. I've already done my hand hygiene and put on my gloves, and I've already prepared the patient. So again, you want to choose a catheter. In the smaller child, you may stay with a soft catheter, or in a larger patient, you may decide to go to a more rigid catheter that will be better for getting more thick oral secretions. Again, you want to make sure that the suction is not too high to not cause any trauma to the mucosa of the mouth. For oral suction, again, if the patient is non-cooperative, you may just need to gently guide their head to keep them from trying to move their head away from you. Just go ahead and apply the suction into the side of the mouth and apply suction, and then go around to the other side. Try to get under the tongue and a little bit up over the tongue, and try to get any pooled secretions in the back of the throat. Do remember to take care in a patient who has a strong gag reflex or has just been fed, due to you don't want them to gag and then vomit any feeds that may still be in the stomach.
Complications. The complications that you may observe include laryngospasm,
Until then.
bronchospasm, a change in vital signs including a decrease in oxygen saturation, trauma or edema to the oral or nasal mucosa, excessive coughing or
Next.
Next. My name is Siti Izzatul. So I will proceed with nebulizer and spacer device. Okay, next. So basically, nebulizer is a device that generates the aerosolized medication from liquid medication. So basically, it takes 5 to 10 minutes to deliver the medication, and it has 3 pipes with tubing that is connected to the generator, nebulizer chamber, and mask. Next. So what can nebulizer deliver? So apart than bronchodilator and glucocorticoid, it can also deliver antibiotic and of course normal and hypertonic saline. Okay, next slide. So what the advantages of using aerosolized drug delivery is first we can deliver the agent directly to the site, to the lung. And also we can decrease the dose that is required to achieve the therapeutic effect. And also it has a faster onset of action. Okay, so we can have a rapid reversal of the site. And also it can reduce systemic side effect. Okay, next slide. So basically how to use and advice for a proper inhalation technique. So position, so the patient need to be upright position, and if the patient on the bed need to more than 45 degrees, and before and after doing the nebulizer, we need to have a baseline respiratory assessment to compare before and after. So how to advise the patient to have a proper inhalation technique? First, ask the patient to have a slow inspiratory breath with occasionally deep breath, and followed by a pause 2 to 3 seconds, holding the breath, and followed by passive exhalation. So if the patient is more breathlessness, we can increase the frequency and duration of the holding breath. So what factors that will affect the aerosol delivery by nebulizer? Basically, it depends on the technical factor and the patient factor. For example, technical factor, the manufacturer of the nebulizer, flow rate, and fill volume. For example, if fill volume is high, flow rate is low, so basically the nebulizer duration will be longer. Okay, then patient factor can depend on the proper technique of the patient, nose versus mouth breathing. I mentioned that mouth breathing is more better rather than using nasal breathing. Okay, next slide. So the concern of drug delivery, nebulizer in crying versus resting infant. So previously, it is believed that when these infant cry, they will have a better inhalation, better large tidal volume, and will receive more of the drug into the lung. However, now, next slide. It is the many study that showed that when the patient cry, actually there is more prolonged expiratory time and greater airway obstruction. And so the drug will deposit more on the face and stomach rather than in the lung, which is nearly 5-fold lower compared to resting infant. So conclusion, we need to keep calm the patient, the infant, or patient that is asleep is much better than crying infant. Then next slide. So I move to spacer device. So a spacer device is basically a device that we attach to the MDI to aid the delivery and increase the effectiveness of the MDI. So who can use spacer? Children and elderly who have poor coordination to the MDI technique. Next slide. So what the advantage of spacer? So we can eliminate the hand breath coordination because the patient need to push the canister of the MDI and also simultaneously inhale. So children usually don't have the coordination. Then we can allow more deposition of the drug in the lung compared to the upper airway. So we can reduce the irritation and fungal infection at the upper airway. So type of spacer device, there are two. For older, there is a mouthpiece. For younger children, there is a mask. And next slide. So how to use? We proceed to the video and on next slide.
How to use the spacer with mask. Shake the metered dose inhaler or evohaler for 3 to 5 seconds. Remove cap from the inhaler. Hold the inhaler upright and attach it to the end of the spacer. Place the mask securely over your mouth and nose. The mask must fit tightly with no gap between the mask and the skin. With the spacer in place, press the top of the inhaler to release one puff of medicine into the spacer. Keep the spacer in place and breathe in and out, normally for 5 to 10 breaths. For another dose, repeat these steps after 1 minute.
Okay, so that is the proper use of spacer. So we need to advise to the parents of the patient. And then we also need to advise on the parent of the patient to how to clean the spacer. So basically, they need to clean the spacer once a week and using warm water and mild detergent. Avoid using hot water or chlorine. Also, dry the spacer only in the room air. Okay, do not microwave the spacer. And also do not rub with brush or towel or tissue to dry the spacer because they can damage the surface of the spacer. So that's all for me.
Ada lagi?
Ada satu lagi video yang Datuk
Zakira tu.
Zakira je.
Mana? Itu je. Banyak darah keluar. Dotamine buat tak banyak. Okay, ada anything else? The good one dia darah sikit keluar. Yang dotamine buat sikit dia. Banyak darah dia keluar tu. Budak-budak. Any question?
Dato' nak tanya yang tadi with that present ada apa ni? Tunggu baby tu asleep. Do we really tunggu baby tu asleep or
baby tu biasanya dah unwell. Biasanya kita dah sidik baby tu dah.
Okay.
Kata budak tu orang ventilator, kita dah kasih ubat sedation dah.
Okay,
kita kena kasih sedation lah. Morfin ke atau domicum. Amida. Any question?
Alright.
Tak ada Finish? Tak ada dah? Okay. Nanti teaching lagi you all? Tak ada kan? Ada lagi?
Not sure.
Seminar dengan tu je lah. Seminar dengan yang ada seminar dengan teaching.
Ya. Okay lah. I pula tahu dah apa yang ada pun tak ada. Confused lah. Okay Okay.
Okay, thank you Dato'.
Thank you Dato'.
Okay
Thank you Dato'.